Thank you for that introduction. Good morning, everyone. My name is Sindhuja Kadambiu. I'm a geriatric oncologist specializing in genitourinary cancers at the University of Rochester in Rochester, New York, in the USA. Thank you, Dr. Naranha, for giving me this opportunity to be a part of this workshop and share with you this talk on my research focus, which is informal caregivers of older adults with cancer. I'd like to start with a clinical vignette. I'd like for you to meet Revati. She's a 74-year-old woman with a medical history of hypertension, diabetes, and arthritis. She lives with her husband, Govind, who's 77 years old, and was recently diagnosed with advanced prostate cancer. She's a sole care provider for her husband. They have 3 children, one of whom lives locally, but they have their own lives and are busy. So in addition to being responsible for all of her household duties, she spends about 30 hours a week providing care to Govind. She accompanies him to all of his appointments. She helps him manage his medications, communicates with his physicians, is an integral part of his healthcare. Overall, she feels satisfied knowing she's providing Govind with good care, but she also notes that her responsibilities have increased, while her social circle and activities have decreased. This is a quote from a qualitative study of caregivers of older adults with cancer that was recently presented by Yang et al. At the most recent SIOG conference that really applies to her. She'd say, he was very active before, and right now it's even difficult for him to walk a few houses out. I don't know how much care he'll need in the future or if we'll need to move, so there's a lot of uncertainty and just frustration. And she notes that in addition, she's not taking care of her own health as she should. She's having to reschedule her own health appointments, and it's really taken a toll, and she's been experiencing some lows. And I think you'd all agree that this is not an uncommon scenario. I'm sure you've seen it with your own patients and their caregivers. In fact, cancer caregivers are a massive population. In the United States, 2.8 million people provide care to a person with cancer, and they provide approximately 63% of the home care to our older adults with cancer. And with the increase in the aging population of patients with cancer and improvement in oncology treatments, the number of informal caregivers is only expected to exponentially increase. So who is an informal caregiver? They're really family or friends who provide unpaid care to our patients outside the clinical setting. And I said with a more of a push for our patients to be cared for at home, we're increasingly dependent on our caregivers to provide our patients with day-to-day care. And when we look at our caregivers who are taking care of patients with cancer compared to non-cancer caregivers, we see that cancer caregivers experience a greater burden from caregiving as shown here. And that they provide much more assistance when it comes to things like activities of daily living, such as toileting and bathing, as well as instrumental activities of daily living, such as housework, transportation, and managing finances. And this is especially true for caregivers of older adults with cancer. Older patients with cancer have high prevalence of age-related conditions, such as comorbidities and geriatric impairments. In a large multi-center study of patients aged 70 and older with advanced cancer, Dr. Mohili et al. Found that 86% of patients had at least 3 or more geriatric assessment domain impairments. In fact, 94% had impaired physical function and 35% had cognitive impairment. As a result, older patients with cancer have increased needs of assistance from caregivers. And the caregivers provide older patients with cancer with an average of 32 hours of care per week. They help our patients in a variety of ways, including self-care, again, such as bathing and toileting and household tasks. We ask them to perform nursing care without training, such as managing symptoms, treatment-related adverse effects, and catheter and ostomy care. And they not only provide emotional support, but really act as advocates communicating with their healthcare providers. They're involved in all aspects of healthcare decision-making as it pertains to the patient and assist even with end-of-life decisions. What we found in a cross-sectional study of 414 caregivers of older adults with cancer is that caregivers themselves are older. Found that 65% of caregivers were over the age of 65. Most were cohabiting partners or spouses, and a significant number, almost 40%, reported comorbidities. And while caregivers do report positive aspects of caregiving, such as deeper relationship with patients and an improved sense of self-worth, caregiving can be difficult for our older caregivers. There can be strains in marital and family relationships, and due to age, as they're already experiencing limited finances, there can be decreased economic security. They experience a decrease in their social network and are more likely to be caring without unpaid help. What we also know is that in vulnerable caregivers or those with prior health conditions, a significant number, found as 32% of vulnerable caregivers, felt their health had suffered as a result of providing care for a patient. They can experience fatigue from inadequate time to rest because they're caring for someone. They're less likely to engage in healthy lifestyle behaviors such as exercise, and more likely to engage in negative behaviors such as increased alcohol use. They're also less likely to be proactive about their own health. And studies have shown that caregiving can result in weight gain, increased cardiovascular disease, and poor immune functioning. And caregivers of our older adults can experience, as a result, significant physical and psychological hardships because of caregiving. Lee Kehoe et al. From our group found that among caregivers of patients aged 70 and older with advanced cancer, 39% of caregivers reported distress, 21% reported anxiety, and 15% reported depression. And our group showed that in older patients, GA impairments can predict poor outcomes in caregivers. And what we've shown is that an increased number of patient geriatric assessment domain impairments leads to increased caregiver depression and lower physical health and quality of life. And the impact of caregiver burden can be significant and can impact not only caregiver health, as I've also already shown, but can result in morbidity and mortality. In a study of 392 spousal caregivers, 56% reported caregiver strain, and these caregivers had 63% increased risk of 4-year mortality, even when controlling for demographics and health status. And caregiver burden, in turn, can lead to poor care for our patients, including increased patient distress, increased risk of hospitalization, and the use of aggressive and unnecessary treatments at the end of life, all leading to increased all-cause mortality in our patients. So although it's not commonly integrated, caregiver burden assessment is important, but it's not routinely done in our healthcare delivery systems. I've shown you an example of a survey that can be used. It's called the Xeric Burden Interview Survey, which has been validated in advanced conditions, including cancer. Its short form includes 12 questions that I've shown here. For example, ask questions such as, do you feel stressed between caring for your relative and trying to meet other responsibilities for your family and work? And really, the recommendations are that this caregiver burden should be measured at any point in contact with the healthcare system of the patient and the caregiver, but especially at the first diagnosed with cancer, and anytime the patient and caregiver presents to the ED or a major emergency department or a major transition is planned. But this is really rarely used in clinical practice, and there's no guidance on how to best manage caregiver burden once it's identified. So how do we identify caregivers at risk for distress and intervene or provide support sooner? This is a conceptual framework that summarizes the contributors to caregiver distress. There are patient and caregiver traits, as well as intensity of care and available support, all play a role. Patient characteristics that lead to greater anxiety and depression in caregivers include poor Eastern Cooperative Oncology Group, or ECOG performance status, solid tumors as opposed to hematologic malignancies, and patients requiring, as I've already alluded to, assistance with ADLs and IADLs, and those having greater symptom burden and emotional distress. Caregiver characteristics, on the other hand, include psychological symptoms, for increased psychological symptoms were younger age, being a spouse, poor health status in the caregiver, lower social support, and having poor coping skills. So really selecting interventions that includes a needs assessment and that can target the priority areas would be particularly effective approach, especially given that both the patient and caregiver's needs are so varied. We recently evaluated the role of caregiver mastery and depression in caregivers of older adults with cancer. We're really interested. Environmental mastery is an individual sense of control over and effectiveness in managing life situations. It reflects a caregiver's ability to cope, adjust, and adapt to problems. It can be assessed with a validated survey such as the REEF Environmental Mastery Subscale, and we hypothesize that higher mastery may attenuate the negative effects of caregiving stress. So to evaluate the effects of mastery on depression in caregivers of older adults with cancer with functional impairments, we performed a secondary analysis of data from a large randomized study conducted by the University of Rochester's National Cancer Institute's Community Oncology Program. The COACH study, conducted by Dr. Supriya Mohili, enrolled older adults with advanced cancer who had at least one GA impairment and their caregivers, and sought to improve communication between patients, caregivers, and oncologists about age-related concerns. Patient functional status was assessed by patient-reported impairments in ADLs or IADLs, and caregivers were asked to complete the REEF Mastery subscale, which is shown here, and the PHQ-2 to assess depression. And the subscale consists of 7 individualized items. Each is scored from 1 to 5 with a total score of between 7 and 35. And higher numbers indicate having a sense of mastery or competence in managing the environment and external activities, including caregiving responsibilities. What we found was that 61% of the patients in this population had impaired function, 15% of caregivers reported depression, and the mean caregiver mastery score was 27.6, with a range between 7 and 35. We found that caregiver mastery moderated the association between patient functional impairment and caregiver depression. So in other words, for each unit increase in the caregiver mastery score, odds of depression decreased by 37% in caregivers of patients with functional impairment compared to 21% in caregivers of patients without functional impairment. So we found that caregiver mastery can attenuate the association between patient functional impairment and increased caregiver depression, suggesting that interventions to increase caregiver mastery may help caregiver emotional health. But there really are a wide range of interventions, such as cognitive, behavioral, complementary or alternative medicine, family or couples, interpersonal, problem solving, or psychoeducational supported therapies that are available for caregivers as possible interventions. They've been shown in a wide range of studies to improve problem solving and caregiving skills, in addition to reducing burden and decreasing depression and anxiety in caregivers. But there's wide variability among these studies, making it difficult to compare between them. And there really is a need for rigorous studies that are adequately powered to examine validated and reliable caregiver outcome measures. In addition, these interventions have mainly been tested in older adults with dementia and in cancer caregivers. There really have been no interventions that have been tested in caregivers of older adults with cancer. And so interventions that are provided to both patients and caregivers would be particularly beneficial in this population. So because our group has shown that geriatric assessment impairments can predict poor outcomes in caregivers, and we know that caregivers of older adults themselves are older with comorbidities and likely also have age-related conditions, we're currently conducting a study to utilize the geriatric assessment in both patients and caregivers to formally assess age-related conditions and the health status of both the caregiver and the patient, and really identify whether the caregiver is able to provide care. This is a pilot study that I'm conducting, with the first phase being to determine whether it's feasible to conduct the geriatric assessment in caregivers in addition to the patients. And I'm planning on enrolling patients over the age of 65 with advanced cancer and their caregivers who are also over the age of 65. We're going to be doing longitudinal assessments with the GA in caregivers over an 8-week period while they're just adjusting to caring for someone with a new diagnosis of cancer. We're also planning to engage key stakeholders, including our community advisory board of older adults with cancer and their caregivers, and geriatric oncology experts from the Cancer and Aging Research Group, as well as primary care providers. Using their input, we're hoping to identify high impact supportive care interventions, as well as procedures to implement these interventions. Our ultimate goal is to develop and pilot a supportive care management algorithm where we can identify caregivers at risk for burden and provide supportive care recommendations. We just received regulatory approval for the study, and we're actively in the process of enrolling both patients and caregivers. So in summary, as take-home messages, I hope I've conveyed that as a population ages, there will be more informal caregivers of older adults with cancer. And older adults with cancer have unique needs as do caregivers. And the caregiver should really be treated as an invisible patient there with us in clinic. And that because they can experience significant burden as well from the patient having a diagnosis of cancer and from caregiving, and they really should be screened. But future studies are required to test and implement these interventions in caregivers of older adults with cancer. And we're hoping to be able to do that. Thank you. And I'll just end. This is our University of Rochester's Geriatric Oncology Research Group program. Without whose support, and none of this would be possible. Thank you.
Thank you very much, Dr. Sindhuja. That was really an insightful and very thought-provoking talk, especially, in the reference of our, in Asian societies, I think caregivers are often taken for granted. And all the more reason for us in India to be, thinking about the caregivers. So thank you so much for your talk. Are there any questions?
Yeah, ma'am. Sindhuja, ma'am, I have a question for you. So definitely, ma'am, you have touched upon a very important topic, which is overlooked. Most of the time we attend conferences and workshops, we are discussing about a caregiver. So this is really, really important for us. So ma'am, what do you suggest that should be done practically to provide more and more support to caregivers? What we should do on a practical level, practical basis in our own society, in our own patients, caregivers, that we can do to improve caregiver support?
Yeah, thank you for that question. I think an important aspect to this is that I think between societies there are going to be different needs of caregivers, right? And I think in different cultural systems that caregivers and that burden can be different. The expectations can be different, how they experience can be different. So I think it's really important to understand what the caregiver needs are. And I don't think that we've quite even done that yet. We don't really know what our caregiver population really looks like and what their needs are. So I think that's the first aspect of it. From a clinical perspective, I think really just thinking about, we always think about the caregiver as, we kind of operationalize the caregiver, right? We only look at them as this person who's helping the patient, as opposed to a person who's also experiencing this diagnosis and treatment. So I think coming from that perspective in clinic with you, really asking the questions of the amount of care that they're providing, is there additional support that they're looking for? Just asking those questions in itself, I think can be really helpful. And I do find that by asking that, I do get a social worker. That's one of the supports that we have, is having a social worker in our clinics to be able to reach out then to see if there's aid services or, home nursing that can be provided as additional support. But those are some of the basic tools that we have right now to be able to support both our patient and our caregivers.
Good. Forming a support group where similar caregivers are given a chance to interact with each other and help each other, would that help?
Yeah, I think that there have been studies, not necessarily in our population, but in other caregiver studies where they have talked about support groups being quite helpful. I think they do find that it helps in terms of understanding educational opportunities, as well as reducing some of the anxiety and mood symptoms that can accompany from caregiving. I think for older caregivers, because they also have that comorbidities and age-related conditions, that can be really impactful. And so I think that just support groups alone can play some role, but I think we need to offer them real substantial support as well.
Thank you.
I can't tell if I'm freezing up or if it's, so hopefully you can hear me.
No, we can hear you well. We can hear you well. At least I can, Dr. Sindhuja.
We can as well here in the venue.
Yeah. So, are there any other comments? Dr. Vanita, would you like to come in and say something?
Yes, I have a couple of questions. Thank you so much. That was a really excellent and insightful talk, Dr. Kadambi. So, a couple of questions for you. We usually do the geriatric assessment right at the start of their cancer journey. What do you suggest is the optimal time to assess caregiver burden? So we assess everything at one go, but I would imagine the caregiver burden would be the least at the start and perhaps build up as they go along. But so your comments on that?
Yeah, I agree with you. So I think that's part of the pilot that we're doing. So we're going to be doing the geriatric assessment for both the patient and the caregiver within 4 weeks of a new diagnosis, and then repeating the assessment 8 weeks after to determine what's changing with the caregiver's health status as well as their caregiver burden. So we'll be doing some qualitative interviews as well as using some surveys to assess burden. I think that'll give us, I'm hoping that'll give us some information. But I agree with you. And I do think that assessing at multiple different time points, knowing what, because even just that initial shock of the diagnosis can be a lot, especially for, the caregiver who may have their own health issues or, difficulties from the beginning. So they may have some burden even from the get-go. So I think even the baseline, just understanding where they are and then following up and repeating would be important.
So, and another question that we face, perhaps this is a more ethnically specific problem. So many times our patients are not accompanied by their primary caregiver. So they come with their grandchild or their child who's actually not doing the caregiving at home, which is the spouse. So and I think we try that when the patient registers for the geriatric clinic, we give out the forms, but by and large they don't get filled out. So and they get filled out when they come to the clinic, and that's not really reflecting the caregiver burden. Do you have any tips for us how to,
I was just curious with COVID, are you doing more telemedicine, or have you been able to do more virtual visits at home?
So no, not yet. We have been trying that. I haven't reached that level of confidence yet. I think perhaps function and falls is the most, I find that the most difficult to assess, as a teleconsult. So there have been many requests. I totally agree with you. And we have been talking in our group that we need to start this, but I haven't, I was talking to Dr. Melissa Lowe, and she was giving me tips as to how to do this electronically, but I haven't yet started.
I think it's so important to have them be present, because you can get such different stories, right, from the patient and from the caregiver, and the way that they're experiencing, a lot of times the patient doesn't always know what their deficits are in the way that the caregiver might, right? So I've had so many times where the patient says, oh, I'm doing fine, I'm doing independent, I'm doing everything. And the caregiver is sitting next to them just shaking their head saying, no, he's forgetting things, he has been falling, it's important for them to be there. And I'm not quite sure how else to bring them into the conversation if they're not coming into the clinic. Because one of the things with the study is also the caregiver is not your patient, right? So there some, so in terms of who's responsible as a physician for the caregiver, that brings up some issues. So it's not as if you can call the caregiver afterwards. I mean, you potentially could have permission from the patient to call and say, can I speak to the person who's at home with you, just to get some sense of how things are going. But I don't know if there would be some barriers to being able to do that after the visit.
I would also, like to say something about it's a bit politically incorrect. Sometimes, we see a spectrum where patients may be very guilty about having fallen ill and having, being a burden. But on the other hand, sometimes there is a lack of sensitivity that the cancer diagnosis also impacts the caregiver enormously. Mm-hmm. And I just wondered whether, you have encountered that, or have the others encountered it, and how one deals with that, because, sometimes there can be a lack of sensitivity towards the needs of the caregiver.
Mm-hmm. Yeah, I think that can be a challenge. And I think that being the caregiver, well, if they do come to clinic with you as that invisible patient, can be helpful. And I do say, if you're both going through this together, it's something that you're both experiencing, and it's difficult on different levels for both of you. So how can I help? And I do think that takes, I think that helps also to let them tell me any ways that I can support both of them. But I think maybe doing those assessments where you're for caregiver burden might be one way also to really understand that piece a little bit more and let the caregiver know that you are also thinking about them.
Yes. I think that the acknowledgement of what the caregiver is doing is so important. Very right.
But if they're not coming into clinic, that can be such a challenge. It has been hard with COVID when we had lockdowns where they weren't able to be in the room. But I put them on the phone. I say, do you want to call them? And then just have them join on the phone so they can be a part of the visit.
Sure.
So, ma'am, caregiving is mostly a culture-based approach. As in India, we see initially the relatives are mostly involved. And with time now, though the scene is changing, the people are getting hired for caregiving too. But we should have a program, basically a counseling session for these caregivers too, that how to go for. As we see in our patients, what we happen, initially when they get diagnosed with cancer, there are many relatives and many person comes as a caregiver. But with time, in due course, and within a 6 months, we hardly find anybody accompanying the patient with time. So this approach has to be with counseling of the basically relatives and the caregivers has to be started in the initial stage only, so that the people can be get staggered over the period of 6 months or a year for giving the care to the patients, and not all the caregivers coming initially in the first month only, and thereafter the patient get left alone. So we have to have a protocol for this.
No, that seems really important. It seems like there needs to be an educational component there when you're doing these assessments, right? To set expectations and ask that. And it sounds like they need to be a little bit more aware of what their role should be moving forward.
My experience has actually been, it's varied. So we have certain communities in India where I feel, this is my assessment over the years, is that, this caregiving has also been thought through. And so there's actually, like a relay. So there'll be a big family and there'll be people who will have planned, who will be with the patient. That kind of family support is actually just enormous. So when it all comes on one person, I think it's very difficult. But when the whole family pitches in and does it in a very organized sort of way, and I've seen that happen with, there are certain communities where what we call the joint family system is very, very, still solid. And then, this has been thought through. So according to everyone's work schedule, duties are assigned. So that's really very nice. I think that's where, so that's, again, as we said, it's cultural. A lot of the caregiving is considered, I should say, it's taken for granted that, of course, it'll be the family, immediate family that'll be done. I don't think there is even an acknowledgement very often of, say, a spouse or a child who may be, or a parent also actually, who might be doing caregiving duties, not for the geriatric population, but patients in general. But on the other hand, I find that there are, especially in joint families, there is a lot of resilience and people kind of come together for this.
That's great. And I think, there are definitely studies showing the importance of social support in general, right? And we see that in our clinics. The patients who have better support tend to do better, right? Cancer outcomes are better, and emotional health, physical health seem to be better when they're well supported.
And also seeking out care if required, counseling and care if required. So we have one more question, and I think this will be the last question before we close this session. Is caregiver burden different with different cancer sites or advanced disease?
It appears to be. There are certain cancer types. It seemed as though solid tumors, for example, had caregivers of patients with solid tumors, for example, GI tumors, seem to experience more burden. That may be because there's, if there are GI cancers, there may be ostomies involved, feeding can be difficult, things like that can make an impact. And advanced disease in itself carries a different burden in that, as opposed to localized disease, advanced disease, I think, also carries a sort of existential crisis, right, of like having a disease that may be incurable. And it may require more prolonged or more intense period of care. So the burden in that is different.
Yeah. So thank you very much, Dr. Kadambiu, for a wonderful session.
Thank you so much for having me.